Good morning. First of all, I would like to thank you all for being here today and the organizer for the invitation to take this talk about Gorham Stout disease. It's a pleasure for us to be here. My name is Ippolita Rana from Rare Disease and Medical Genetic Unit of Bambino Gesù Children's Hospital in Rome, Italy. And let me introduce my Dr. Sabrina Bonuomo, who works with me in the same department and is involved in Gorham Stout disease patient care as well.
Hi, everybody.
Our presentation will be divided in 4 parts. First, I will review what we presently know about Gorham Stout disease. And then I present our case series collected in our hospital. Third, I will show the therapeutic options so far available. And last, few hints about future approach to understanding pathophysiology of Gorham Stout disease. So let's start. Gorham Stout disease is also named Vanishing Bone Disease or invasive hemangiomatosis, is an ultra-rare condition characterized by progressive osteolysis with intraosseous lymphatic vessel proliferation and bone cortical loss. Up to date, about 300 cases have been reported, and this is not only due to the rarity of the disease, but probably also due to the diagnostic difficulties caused by its wide variety of clinical presentation. In fact, many patients go undiagnosed from months to years after the onset of symptoms. It may occur at any age, but more commonly affects children and young adults. And the disease does not show a clear gender or ethnic bias or inheritance pattern. So here is reported the classification of vascular anomalies. In 2014, the International Society for the Study of Vascular Anomalies, ISSVA, updated Gorham Stout classification at its 20th workshop. The ISSVA classified Gorham Stout disease as a complex lymphatic anomalies, CLA, with clinical feature overlapping other disease which belong to the CLA family, as Gorham Stout disease, general lymphatic anomalies, caposiform lymphatic anomalies, and central conducting lymphatic anomalies. CLAs overlap their clinical symptoms and characteristics, and as we know, lymphatic malformation are difficult to diagnose. However, some characteristics like osteolytic lesion are useful for distinguish between CLAs. In fact, Gorham Stout disease is characterized by progressive osteolysis and cortical resorption, not observed in other CLAs, where osteolysis, if present, is confined to the medullary cavity. So the ISSVA classification has been promoted to spread correct understanding of vascular anomalies, and actually the correction and the simplification of that terminology and the systematization of guidelines have promoted a more uniform approach in carrying out research and diagnosing vascular anomalies. This diagram shows mutation and signaling pathway involved in the pathogenesis of lymphatic malformation. As we know, lymphatic malformation are sporadic, not familial, and can be caused by somatic change in RAS mitogen activated protein pathway or in PI3K, AKT, mTOR signaling pathway that both lead to proliferation, cell growth, differentiation, and angiogenesis. The mechanism behind the osteolysis in Gorham Stout disease are unknown, but various hypotheses have been proposed. What we know is that lymphangiogenesis and the activation of osteoclasts are essential for the development of Gorham Stout disease and are repeatedly observed in its lesions. One hypothesis is that osteolytic lesion in Gorham Stout disease is associated with local and abnormal proliferation of lymphatic vessels, possibly causing bone compression and subsequent bone resorption osteolysis. However, the mechanism of and triggers of invasion of lymphatic endothelial cells into bone remain uncertain. The endothelial cells express vascular endothelial growth factor receptors, and vascular endothelial growth factor signaling plays an important role in angiogenesis and lymphangiogenesis. Also, the role of osteoclasts in Gorham Stout disease is controversial. Recently, our research team in an experimental setting demonstrated that osteoclast differentiation and activity is increased in cultures of cells isolated from our patient. Moreover, Gorham Stout disease osteoblasts differentiated from mesenchymal stem cell showed reduced ability to mineralize bone. These cell autonomous defects can be enhanced by systemic factor contributing to the alteration of bone remodeling. And then the activity of osteoclasts is influenced by some cytokines that are secreted by the lymphatic endothelial cells. And moreover, activation of osteoclastogenic process is induced by immunomechanism and stimulation of Treg cell in affected bone tissue. Okay, and now we proceed. The clinical presentation of Gorham Stout disease is highly heterogeneous. It varies according to the involved skeletal segment and to the extension of the lesions. Gorham Stout disease can develop at any site. Ribs, skull, clavicle, and cervical spine are more frequently involved. However, pelvis, humerus, scapula, and femur can be affected as well. Here we report the imaging study of 3 patients followed in our hospital. The first one on the left is a 4 years boy who had a left femur pathological fracture at the age of 2 years. After 18 months, he was admitted for pain and limping, and the X-ray, MRI, and CT scan documented extensive osteolysis with disappearing of the left femur completely replaced by soft tissue. The other patient is a 3 years boy diagnosed at birth with cystic lymphangioma of head and neck associated with a capillary vascular malformation. After 1 year, a CT scan and brain MRI revealed the bone resorption of the skull base. The last patient is a 6 boy admitted for extensive swelling of axillary and left dorsal region. Thoracic X-ray and CT scan showed a massive left side pleural effusion. Therapeutic thoracentesis revealed milky white fluid consistent with chilothorax. and CT scan and thoracic MRI documented osteolytic alteration affecting the vertebral bodies, left scapula, left humerus, and ribs. After few months, the CT scan revealed the complete, as you can see, the complete resorption of several ribs. In this table, published on Lymphology in 2021, we report the principal characteristic of named patient followed at our hospital in Rome. Clinical and radiological and histological features are reported. Moreover, starting from 2016, we defined a diagnostic therapeutic protocol in order to uniform the clinical path for all the patients referred to our hospital. Based on this internal statement, the diagnoses were supported by clinical, radiological, and histological data according to criteria proposed by EFEDS in 1983 and the ISSVA classification. The biopsy was considered the gold standard diagnostic criteria, and other conditions that may cause bone resorption, endocrine, malignancy, metabolic, infectious, were excluded. As you can see from this table, localization and age of presentation of Gorham Stout disease greatly varies from prenatal and 6 years. The time span between symptoms appearance at the onset of the disease and diagnosis varies as well, from 2 months to 25 years. The involved sites observed in our series were skull, vertebral column, humerus, sacrum, ilium, ribs, femur, mandible, and scapula. The clinical presentation at the onset of Gorham Stout disease is heterogeneous. It varies according to the bone localization. And so we can have pain, fractures, functional impairment. 2 patients, patient 3 and 6, had dyspnea due to kilothorax. And this is important red flag to keep in mind, since it is a really risk of severe respiratory distress. Another symptom could be meningitis. All the patients with skull-based lesion, patient 4, 7, and 8, experience meningitis. That is one of life-threatening complications in Gorham Stout disease. Most patients showed, as you can see, multiple bone osteolysis. Only one had a monostotic lesion, patient 9. 3 out of 9 revealed a massive destruction with the disappearing of affected bone, as I showed you in the previous images. All the patients, as you can see, underwent to biopsy of the bone lesion, considered the gold standard diagnostic criteria. The biopsy showed a benign vascular malformation, simple or combined, according to ISSVA classification, with progressive osteolysis, cortical resorption, and activation of osteoclasts. Here is reported the bone biopsy of a patient, of our patient, with pathological characteristic of Gorham Stout disease. And as you can see, vascular lesion, according to the ISSVA, are identified immunohistochemically by positivity for vessel marker CD34 and CD31, and lymphatic endothelium marker D240. Now we So treatment plan was established in our case series, was established according to recent literature and data, and after a multidisciplinary consulting group dedicated to Gorham Stout disease, including clinicians from different specialties, pathologists and basic scientists. The decision to start therapy was principally based on presence of symptoms and or rapidly progression of the disease. From 2016, an identical schedule was administered to every patient who was considered to undergo treatment. As you can see in this here, in this table, 7 patients received a treatment, 4 with sirolimus and zoledronic acid, 2 with interferon plus bisphosphonates, and 1 with bisphosphonates alone because they were hospitalized before our therapeutic protocol was started. 2 patients, patient 8 and patient 9, did not receive any treatment for a stable disease since more than 3 years. The disease is progressive in most patients, although few cases are self-limiting. The most common symptoms is localized pain, but swelling, weakness, and functional impairment of affected limbs may also occur, as we already seen. Asymptomatic cases have been reported as well as cases diagnosed after a pathological fracture. As we saw, patients with thoracic involvement with scapula vertebrae may develop a chylothorax due to the propagation of the disease to the pleural cavity or the thoracic duct. And this occurs in approximately 25% of Gorham Stout disease patients and can result in respiratory distress and failure. Another complication is meningitis. The patient with a skull-base lesion can develop a meningitis that is one of the life-threatening complications of Gorham Stout disease. The interruption of the blood-brain barrier due to the osteolytic lesion facilitate the meningeal infection by microbial agents from upper airways. And now let's go to the therapy. The appropriate treatment remain unsettled. Surgical strategies are definitely indicated in case of pathological fracture. Radiotherapy with moderate dose was attempted in several adult patients, yet its role remains controversial and should be avoided in pediatric patients due to the long-term sequelae such as radiation-induced malignancy and inhibition of skeletal growth. Medical treatment include, as you can see, interferon alpha, bevacizumab, sirolimus, propranolol steroids, vitamin D. Multiple case series and reports describe treatment algorithm of different institutions, but there is not yet a consensus or indication for static medication, initial dosing adjustment, frequency of monitoring, or length of therapy. Here we report a recent paper published on pediatric blood cancer concerning treatment option. Improved understanding of pathogenesis for lymphatic anomalies lead to use of mTOR inhibitors such as sirolimus and everolimus, biphosphonates, and more recently MAPK, MEK inhibitors like trametinib. PIK3CA inhibitors like alpelisib are also potential treatment options in the future. future. Okay. Above all, the way that DNA and RNA aberration lead to Gorham Stout disease is fully understood due to the limited number of studies focusing on this rare disease. Recent advances in multi-omic analysis reveal selected topics as new potential drivers in the disease. Here, a gene of family of tumor necrosis factor receptor superfamily member 10A, previously identified as mutated in a scapular Gorham Stout disease lesion, was detected among the top 5 mutated genes showing multiple deletion, insertion, and point mutation. The tumor necrosis factor receptor superfamily 11A, a member of the same family of genes, linked to muscular dystrophy and osteolysis, was also reported in a previous case of a Gorham Stout patient. The gene fusion of ATG 101 and SLC4A8 involving in a binding protein essential for macroautophagy was also reported. And finally, the alteration of P10 Pediatric AKT signaling cascade were not only observed by mutation of some of the members of the pathway, but also reported as gene expression change in the RNA sequencing data. The modification of the PI3K pathway are known to cause lymphatic malformation, and during recent years have become the main target for inhibitor therapies designed to decrease vascular endothelial growth factor secretion and angiogenesis. As with any rare disease, the inclusion of further Gorham Stout disease patient in the future with a combined genomic and transcriptomic profile could confirm the insight here reported and the mechanism of the mechanism of the disease. Finally, recent clinical and scientific findings have improved the knowledge of genetic and pathophysiology of Gorham Stout disease and changed the treatment approach, although so far no standardized treatment is available. Early and accurate diagnosis is essential for optimum management of Gorham Stout disease to control disease progression and complication, ensuring a better quality of life for this patient. And our experience highlights the crucial role of multidisciplinary care as a key resource for the management and assistance of patients with such a rare disease. And so, thank you all for being here today.